Hello everybody, this is ultrasound community and we would like to share with you this case of the week. This is a 55-year-old male who's not known to have any medical illness. He was referred from other hospital because of shortness of breath for 3 days and the dyspnea started suddenly. So he was managed there as bronchial asthma. Then he was referred to our hospital for further management. Blood pressure of 110/70. He was tachycardic, afebrile, and his oxygen saturation was 90% or room air. On examination, the patient was obese and he was sitting and he cannot lie down. He is tachypneic. Chest examination was clear to auscultation. Cardiovascular exam, he was tachycardic and it was regular. There was no lower limb swelling and no signs of DVT. So our working differential diagnosis: COPD, asthma, is it myocardial infarction, congestive heart failure, is it pulmonary embolism, pneumonia, pneumothorax. Now to approach the diagnosis, we could do chest X-ray, ECG and echocardiography. Now chest X-ray did not show any clear infiltration suggestive of pneumonia. It is not suggestive of pulmonary edema as well. So next step to do ECG, looking for any signs of ST elevation, MI or ventricular tachycardia, for example, as tachyarrhythmia as a cause of the shortness of breath. Here it is a clear sinus tachycardia with a rate of around 150 per minute. There is no ST elevation except for lead 3 with T-wave inversion, and we notice here there is deep S-wave in lead 1 AVL, and there is Q wave in lead 3 plus the T wave inversion. So all these signs what is called S1 Q3 T3 pattern, which is suggestive of right ventricular strain, although it is not sensitive nor specific, but it might be suggestive of right ventricular strain. And the sensitivity of this pattern reported variably from 7% to even 50%, depends on the population studied. This is a closer look of the ECG. Again, S1 Q3 T3 pattern. So based on these findings, clinical history, ECG, we kept pulmonary embolism on the higher list of suspicion. Now, bedside echocardiography was done, and this is apical 4-chamber view. The patient was obese and he cannot lie down, so technically it was very difficult to do, and this is the best image we could get. But it is very clear here that this is the left side of the heart, this is the right side of the heart. It is very clear that right ventricle is dilated compared to the LV, and the septum is pushed toward the left ventricle, suggestive of high right ventricular pressure. This is parasternal long axis view. Left ventricular function looks normal, but the right ventricle looks dilated. Although the apical 4-chamber is much clear, and you see the right ventricle is dilated, so the RV-LV ratio is high. So if we combine all of these data, clinical history, chest X-ray, ECG and the echocardiography, all these suggestive of right ventricular strain pattern, so we treated the patient as pulmonary embolism. The next step now is to move toward CT angiography to rule out pulmonary embolism. But unfortunately, because of high creatinine of the patient, CT was not done, and high quality echocardiography was done next day and shows dilated right ventricle, dilated right atrium, severe tricuspid regurg, severe pulmonary hypertension and good LV systolic function. So based on this data, he was treated as acute pulmonary embolism, so he was anticoagulated with heparin as well as warfarin for long-term anticoagulation. To read more on ECG findings and pulmonary embolism, please go to this website where there's a short case presentation with summarized with the sensitivity and specificity of each finding. For echo findings in pulmonary embolism, go to this website. Again, you will find a summary of the findings and how accurate it is.